Great. So good afternoon, everyone. Thank you so much for joining us at this very special grand round in honor of our esteemed colleague, Dr. Tom Findlay. We are very grateful to be joined today by Patricia Findlay, Tom's wife, his family, and many, many friends this afternoon. Thank you so much for being with us today. Dr. Findlay was a physiatrist and a researcher. He was in the Department of Physical Medicine and Rehabilitation at Rutgers, New Jersey Medical School for many, many years and served as the director of research. I got to know Dr. Findlay in about 2010 when I first invited him to give grand rounds in New York City. He gave a phenomenal lecture on his incredible work on fascia and the extracellular matrix and its effects on movement. I have to tell you that I still remember that lecture vividly as it changed the course of my own thinking and research. What struck me then was how he was unafraid to explore new territories. Few people then knew very much about fascia. When Dr. Findlay approached us to do research on exercise therapy in cancer, he brought that same spirit of exploration. He had brilliant ideas and needed a team to execute on them. We are so honored and humbled that he chose us. Dr. Findlay has given us the greatest gift of all, and that is the gift of a spirit of exploration and a very clear mission to follow. We thank the Findlay family for sharing Tom with us. He is forever part of our own rehab family. We hope that you will stay connected, and we will be sure to update you on our progress. It was Dr. Findlay's wish that we invite Dr. Lee Jones to learn about his use of exercise in oncology. Thank you, Dr. Jones, for joining us today. Dr. Jones did his training in sport and exercise science at Brighton University in England. Then he did a master's in health psychology, exercise behavior and cardiac rehabilitation at Lakehead University in Ontario, Canada, followed by a Ph.D. in exercise oncology and health psychology at the University of Alberta in Edmonton, Canada, and then a fellowship in exercise oncology at the Cross Cancer Institute, also at the University of Alberta. He is currently at Memorial Sloan Kettering Cancer Center, where he serves as the Chief of the Exercise Oncology Service at the Department of Medicine in the Division of Solid Tumor Oncology. Without further ado, Dr. Lee Jones. I'll stop sharing.
Okay, thank you so much. I'll just pull up my screen. Can everybody see that okay? Hopefully so. Well, first of all, it's an absolute pleasure to be here, and I'm very honored and humbled actually to give this lecture in honor of Tom. I really am. It's pretty incredible for me to be here. Unfortunately, I only met Tom once, but I think similar to you, my experience with Tom was I have very vivid memories. We had a Zoom call, of course, during COVID about a year ago. And we were on a call for about an hour, and Tom just grilled me actually for about an hour about our studies, what we're doing, how we're doing it. And I remember coming away from the call, and I just felt invigorated actually, because it was really somebody who was, you could tell just how deeply excited he was and intrigued about research and really finding out, getting to the true answers of how we can help individuals with cancer, and exercise being one of those avenues. So it was a great conversation that just stuck with me, and I was deeply saddened to hear of his passing, and again deeply humbled that I get the opportunity to still present today in his honor. So thank you again for the invitation. So over the next 45 minutes or so, I'll just set my timer so I stay on track here. I'm going to talk about some of the work that we've been doing I would guess over the past 20 years or so, believe it or not, we've been in this field of what we now call exercise oncology. And so hopefully this is new information to some of you, and I'm also going to present some new data today, hopefully that will be of interest, and I'm happy to answer any questions at the end. So I have no relevant conflict of interest. So today I'm basically going to divide the talk into three compartments. The first I will briefly describe about characterization of physiological toxicity in individuals with cancer. I think this is very important before we think about exercise, is how do we first characterize what I consider to be physiological toxicity. In the second part then I'll talk about the evidence from our group as well from other groups about supporting the role of exercise both to mitigate and prevent physiological toxicity in individuals that are either initiating, going through, or have completed cancer therapy. And then briefly in the final section, I will touch upon where I think exercise rehabilitation in cancer may go, and just give us some of my, if you will, my blue sky vision of where I think rehab might go. So just part one, characterization of physiological toxicity. So I'll just start with this, and this is going to be well known to the audience, but when I first got introduced to oncology, again, this was over 15 years ago when I started my Ph.D. in Edmonton, Alberta, Canada. I would be recruiting individuals with cancer to our exercise studies, and I became pretty fascinated by the fact that the way that physiological function impairments were really characterized in individuals with cancer. And really, it came down to single organ assessment. For example, if individuals were going to go on to certain forms of chemotherapy, there'd be a resting measure of cardiac function. Individuals who might be going on to thoracic radiation might receive a resting measure of lung function using pulmonary function tests. But this was really like single organ assessment in patients that were in the resting state. And so coming from an exercise physiology background, and certainly my background in cardiac rehab, I was kind of fascinated how additional assessments weren't used in individuals with cancer. And so it became pretty clear to our group that although cancer is a little bit different, of course, than cardiovascular disease, it appeared that individuals that were going through cancer treatment were experiencing a lot of the same impairments that individuals with cardiovascular disease also might be incurring. We know that individuals with cancer are typically a little bit older, so of course they present with a lot of comorbid conditions in their cancer diagnosis. There's then the direct hit, if you will, from the different therapies that individuals might be receiving. We know that different types of therapies can cause damage to the different components of the cardiovascular system, be it that the heart, the lungs, the vasculature, or even the skeletal muscle. And at the same time, of course, as individuals go through therapy, we know there's also effects that are secondary to treatment, things like deconditioning or inactivity. Patients become more inactive, of course, during their treatment. They gain weight, body composition changes. So we wrote a paper back in 2007 that we called this a multiple hit. As individuals go through therapy, they get a series of hits to the cardiovascular system that can cause impairments across the entire system. So instead, and rather than thinking about this from the perspective of single organ assessment, what is the integrative damage that might be happening or occurring across the entire cardiovascular system? So from my exercise physiology background, this is the way that we started to think about individuals in going through cancer therapy who had these treatments that might go through this multiple hit. So instead of just thinking about single organ assessment, we started to think about how can you look at integrative organ function, cardiovascular function in these individuals. And arguably one of the best ways to do that is through exercise testing. Now, this is not use of exercise as an intervention. This is the use of exercise to basically to perturb the cardiovascular system so you can measure how well that system functions. And so with these tests, you can put individuals on a bike or a treadmill. These are probably well known to the audience. the gold standard assessment of integrative cardiovascular function is using something called the cardiopulmonary exercise test, that you can measure something called VO2 peak, or the volume of oxygen consumed per kilogram of body mass in an individual who's going through exercise. So essentially, you can put individuals on a treadmill, you make them walk up a steeper and steeper hill. At the same time, you're measuring their heart to make sure it's safe for them to exercise, and you're also measuring gas exchange information. And so you can measure how much oxygen they're consuming during exercise. And this is something called VO2 peak, sometimes also called VO2 max. So this gives you an idea of how efficient this individual is at bringing in oxygen from the environment and delivering that oxygen down to the muscle mitochondria. And we can measure this, and this gives us a very good measure of the cardiovascular function of an individual. So just to put this into context, VO2 peak, or cardiovascular function, in humans can range from anywhere from 10 milliliters of oxygen per kilogram of body mass. This might be an individual, say, with heart failure, all the way up to the Olympic athletes, which are literally off the chart. They could have VO2 peaks of 80, 85, and even above. So this is the range of VO2 peak in humans. This is age here on the x-axis. And what you can see right away is as we get older, our fitness declines. So that's just age. It gets to all of us. So your fitness is determined basically by two things. One is your genetics. The second thing is your level of exercise behavior or physical activity. So individuals who are endurance trained, these have the highest level of fitness across the entire age continuum. These are individuals who are active, and these are individuals who are the sedentary individuals. So these individuals have the lowest fitness across the entire age continuum. I'm just referencing here a VO2 peak of 15. This is considered to be the lowest VO2 peak for independent living, which is really important landmark, of course, and I'll talk about this a little bit later. So this has been our measure of how we can assess the impact of cancer therapy in individuals who are going through cancer therapy. So when we first got into this field, we started with a hypothesis, and because we were very interested how fitness might change as an individual is diagnosed with cancer or certain types of cancer, and how that might change as individuals then progress through their cancer journey. So on the y-axis here, we have cardiovascular reserve capacity, or if you will, a person's VO2 peak, and this is essentially time along the x-axis. The blue line represents what we know as the normal age-related decline in someone's fitness level as they get older. The yellow line depicts what we thought might happen in an individual who's been diagnosed with cancer. So at first, there isn't much difference, of course, at the point of diagnosis between an individual without cancer versus one of those who's with cancer. And then at section B, this is when treatment hits. And at that point, we hypothesized there'd be a significant decline in someone's cardiovascular reserve capacity. Once treatment was finished, the common notion was that, well, of course, treatment is finished now, fitness spontaneously recovers and then continues on the normal age-related decline. But is this true? Or does fitness not recover at all? It just actually flatlines and then continues on the normal age-related decline? Or in individuals with cancer, do they get a decline during treatment, and then does this continue to decline even after therapy? Of course, if you look at the normal age-related decline, individuals who've been through cancer therapy who might have experienced this significant decline, or which we thought there might be a significant decline, these individuals would hit these important milestones, such as overt clinical dysfunction, a lot earlier if they've been through cancer therapy, compared to individuals who'd not been through cancer therapy. So we thought there might be a big hit, and this big hit would have clinical consequences in individuals who have been through cancer therapy. So we then started to test this model and find out whether this model was actually true or not. So I'm going to summarize a lot of data in just one slide, but essentially over the past 10 to 15 years or so, there's now been multiple studies that have been reported showing that there's this accelerated significant decline in someone's cardiovascular reserve capacity or their fitness level as they go through cancer therapy. And in fact, if you look at 3 to 6 months of cancer therapy, and this could be chemotherapy, could be hormone therapy, could be radiation therapy. The degree of decline depends a little bit on the type of therapy and the intensity of therapy. But in general, there's anywhere from a 10 to 20% decline in someone's fitness level in about 3 to 6 months of therapy. And people would say, well, Lee, of course, this is going to happen. These individuals are getting pretty heavy-duty aggressive therapy. Of course, you're going to see this decline. But I think what's important to keep in context is typically we see a 10% decline of fitness normally over 10 years of aging in an individual who's not going through cancer therapy. So in other words, 3 to 6 months of cancer therapy was the equivalent to 10 years of normal aging. And if you speak to individuals who've been through cancer therapy, they will tell you this. They will tell you that they feel 10 years older than they did before they started on their cancer journey. And so we and other groups have now quantified this using these objective measures to actually prove that that is the case. So the next question is, if indeed you do see this rapid decline during treatment, what happens after the completion of treatment? Does it spontaneously recover? What happens? So we've also done several studies in that space as well. I'm just going to summarize 2 of those very, very quickly. So the first study was from our group, which we published now a few years ago, almost a decade ago, I guess. And this was a very simple study. This was in 140 women with early stage breast cancer who completed their chemotherapy or their radiotherapy at least 3 years prior to them coming into the study. So very simply, we brought these women into our lab. We put them on a bike to test their fitness, and then we compared their fitness levels to women of the same age who had not been diagnosed with breast cancer and not been through breast cancer therapy. And these were the data, and I think they're pretty informative. So this is VO2 peak range from 10 to 30 that was measured, and then we looked at VO2 peak per decade of life. So this is in individuals who are age 50, 60, and 70. The red represents the women with breast cancer. The blue represents the age-matched women or the healthy controls. And I think what you can see right away is compared to the women with breast cancer where we measured their fitness levels, the women who had not been through breast cancer therapy across all for all decades of life had a significantly higher level of fitness. I think what's kind of telling about this, if you look at the median or the mean VO2 peak for a woman who's been diagnosed with breast cancer, who on average is age 50, you can see their VO2 peak is around about 20. The same VO2 peak in a woman who's not been diagnosed with breast cancer occurs on average at age 70. So from a physiological perspective, our breast cancer survivors are operating actually 20 years older from a physiological perspective than women who've not been through cancer therapy. Another study published about 7 years after ours, and this is in adult survivors of childhood cancer. So these are individuals who were diagnosed with cancer as children, treated as children, and then they've been in long-term follow-up. This is then bringing these individuals into a laboratory for testing of fitness 26 years following the completion of their therapy. So this is again VO2 peak ranging from 10 to 35. This is the group whether these individuals were treated with a chemotherapy that included a type of chemotherapy called adriamycin. These are individuals who got chemotherapy that did not contain this particular type of chemotherapy called adriamycin, and this is the healthy controls. And again, you can see the results very clearly. These individuals, even though they're almost 30 years following the completion of their therapy, still have a fitness level that on average is about 21% below individuals of the same age, the same sex, who have not been through cancer treatment. So not only do you see this rapid decline during treatment, but it doesn't appear to recover, at least in the context of these studies. So the next thing we wanted to look at is, what does this mean? We know that low fitness is associated with outcomes such as patients might report lower quality of life, they might feel more fatigued, and low fitness is important for many other disease conditions. But we wanted to know, is this clinically important in individuals with cancer? And there's a couple of studies that have looked at that. So this is the first study we looked at, and this was in almost 400 individuals with lung cancer, and we measured fitness levels in these individuals. We basically split these individuals into whether they had high fitness, moderate fitness, or low fitness. And then we looked at the longevity in these individuals. Long story short, compared to those individuals that are high or moderate fitness, those of low fitness had the shortest survival time. And this is active for controlling for things like age, cancer treatment, and other prognostic markers in individuals with lung cancer. So this was, I think, one of the first studies showing that fitness had prognostic importance in individuals with lung cancer. Since that time, we also published a second study. This was published just a year ago. This was in 1,600 individuals with various forms of cancer. We didn't measure VO2 peak in these individuals, but we estimated this was exercise capacity on a treadmill with indirect measurement of their VO2 peak. So this is a peak MET, about 5 years of follow-up. Again, we split these individuals either into low fitness, moderate fitness, or high fitness. And of course, I think the data is self-explanatory here. Compared to those individuals of high and moderate fitness, really not too much difference between them. The high fitness groups lives the longest, but you can see the high risk of premature mortality in the individuals of low fitness, showing again that those of moderate and high fitness, it appears to be protective. So that hit to the system appears to be very clinically significant for many reasons, including poorer survival rates in individuals who have been diagnosed with cancer. So just to summarize this first part, if you go back to our conceptual model, I think we and others have now shown that you get this rapid decline in someone's cardiovascular reserve capacity as they go through cancer therapy. This has really led to the notion of cancer therapy being associated with accelerated aging or accelerated physiologic aging. Other aging phenotypes such as cognition and other things have also been linked to this phenomenon. And at least appear to our data, it doesn't appear to continue decline. I would argue that it appears to flatline, but doesn't spontaneously recover, which I think is very important. And we've also shown, of course, if your fitness stays low, that also might predict for poorer longevity in these individuals. So this now brings us on to the second part, is what can we do about it? So if that's the bad news, what can you do about it to either prevent or mitigate the effects of cancer therapy on things like cardiorespiratory fitness, cardiovascular reserve capacity? And in this respect, we've really thought about this from a NASA approach, a space flight approach. You might find it's a little bit strange to be thinking about space flight and what's NASA and space flight got to do with oncology, but there's actually a lot of parallels between these two disciplines. When an astronaut is preparing for space flight, they will go through an exercise training program both before they go on their mission. During space flight, they also will perform exercise training in space, believe it or not. And as soon as they come back to Earth, they also will engage in post-flight exercise training. So we thought this was very analogous what might happen with an individual going through cancer. Could you think about it in a similar kind of fashion? Could you think about exercise training before an individual starts cancer therapy? Can you think about exercise training during their cancer therapy to try and offset some of the potential effects of cancer therapy on the cardiovascular system? And even following the completion of therapy, can you think about exercise training there to help recover these individuals? So this is the way that we've been thinking about it. So over the next little bit, I'm going to split my talk up into studies that have looked at exercise before cancer treatment, those during cancer treatment, and those after cancer treatment. Now, there's been a lot of studies that have been published over the past 15 to 20 years, so I'm not going to be able to summarize all those studies, of course, but I'll just hopefully just give you a flavor of some of the work in these areas. So what about pre-rehabilitation? So to confess, this is an area that I really haven't followed too much, but there's been an explosion of interest in the role of prehab in individuals with cancer, particularly those who are going for pretty major surgeries to see if we can lower complication rate. And so to do this talk, I actually pulled up a couple of recent papers just to get a sense of this data. And so these are two recent studies. I'm not going to go through these studies in any great detail, just to say that these were both both studies were individuals with colorectal cancer, which is a pretty major surgery. And this is short-term physical activity, exercise advice in the period before these individuals were going through cancer surgery. Again, I'm not going to go through these studies in any great detail, only to say that both of these studies were negative. The role of prehabilitation in both these studies failed to improve surgical recovery in both of these studies. And you know, this study here is this is a large randomized controlled trial, 761, and it seems to be that's really the status. And hopefully, maybe somebody can correct me, but in prehab, I think there's been a lot of efforts here, but the studies to date have been a little bit disappointing. I think one of the major reasons for that, of course, is we've got a very short window of time between diagnosis and surgery in which to intervene. And so these studies are doing, you know, asking individuals to do a little bit more physical activity, but the impact has been minimal to date. At least that's been my read of it. So we've been doing a study here at MSK that I think it might be relevant to the setting. Now, this study actually is not designed to look at the impact of exercise on surgical complications. It is designed to look at the impact of exercise on tumor biology in men with prostate cancer. But I think these findings might be relevant to the preoperative setting. So this is a phase 1A, phase 1B study. It's essentially a dose escalation of exercise in the preoperative window of opportunity. So we're taking about 40 men with prostate cancer, all of which have to be inactive to get into our study in the first place. These men get then assigned to one of 6 different escalated doses of exercise. So the lowest dose is 90 minutes of exercise per week. The highest dose, believe it or not, is 450 minutes of exercise per week. And this ranges anywhere from 3 to 12 weeks, depending on how long the individual has before their surgical intervention. As I mentioned, this is a phase 1B study as well. So we're going to identify what we consider to be the maximal feasible dose of exercise in this setting. We'll then recruit an independent sample of 20 patients and run them through the same dose. And again, this is not designed for surgical complications, but I just wanted to share this with you because I think some of the findings might be relevant, which I'm going to share with you next. Now, I think importantly, one of the limitations, of course, of these preoperative prehab studies is having sufficient time to exercise individuals before they go for surgery because it's a short window of opportunity. Now, most of the approaches to exercise training in the prehab as well as after cancer treatment has been using a facility-based approach. This is where we bring individuals into our facility so we can monitor every single exercise session to ensure that we prescribe exercise correctly and to actually quantify exactly what individuals did. This is the way that we've done to really make sure we're delivering high fidelity exercise to our individuals with cancer. The problem with this, of course, it's highly inconvenient to get individuals to travel into a center even 3 days a week. Imagine trying to get somebody in 5 days a week for an extended period of time. It's expensive. This has led to slow accrual, which has been obviously problematic. So with this particular study, we knew we had to design an alternative approach if we were going to be able to do exercise studies at high fidelity that didn't involve the inconvenience of coming into a center. So we designed something called DigitX, which basically puts together a bunch of digital solutions and devices together with advanced analytics that now allows us, I think, to address some of the major barriers we've had to delivering exercise at high fidelity in all clinical populations, including those with cancer. So when individuals come into our studies, we send them a study kit. This includes a treadmill, so we send individuals a treadmill. This comes with an iPad, health watch, Bluetooth, scale, blood pressure cuff, and also a glucose monitor. So we send these to our individual participants. All this data, all the apps are connected to the iPad. All this data flows through something called Validica Cloud. It comes in all passively, so we can collect information on individuals basically 24/7 that they're in the study. And then we can use this information, it comes into MSK, we can real-time visualize whether individuals are wearing the devices, not what these devices are telling us. And of course, we can monitor these individuals now in real time while they're doing their exercise sessions. So this is what it looks like. So to get around the issue of convenience, everything is done remotely in our trials, including the informed consent. We can do that remotely. Because we send them a treadmill, we can do a fitness assessment in their home. This is a sub-maximal exercise assessment. Every single exercise session is also done remotely in the person's home with one-on-one real-time monitoring by your exercise physiologists that are sitting here in Manhattan, in New York City. We collect a lot of biospecimens in our protocols, but instead of asking individuals to come into MSK to give us biospecimens or blood draw, we send a company to their home also to collect the samples. So in other words, an individual never needs to leave their home to do all the study procedures. And because we send them all these different devices, we're now able to, I think, characterize the physiological impact of exercise in a manner that's never been previously possible. For example, with the health watch that we give them, we now get a heart rate reading every 10 minutes, 24/7. We get a blood pressure reading every day. We get a body composition every day. Which is obviously a lot different than just getting a reading maybe just during an exercise session or baseline and post-intervention. This comes into our systems, we're able to analyze it. And some of our studies were also getting, as I mentioned, biospecimens. I'm not really going to talk too much about that today, but just telling you what we're doing in the context of some of our studies. So to get back to the preoperative study and prehab, again, was not designed to look at surgical complications, but I just wanted to share with you some of the fitness data that we've collected in the study. Again, I think it's instructive to maybe the future of some prehab studies. So in these individuals, we measured submaximal exercise, both at the beginning of the intervention, again at the end. And this is just some of the data. This has not been peer reviewed yet, so you can take this with a pinch of salt. This is percent change or delta change in fitness. This is the individuals who did 90 minutes a week, 150 minutes of exercise a week, 375, and 450. Each line represents an individual patient. As you can see, we've got 26 patients who have been through this study to date. Those who did 90 minutes got about a 6% improvement in fitness, 17% with 150 minutes, 19% with 375, and almost a 50% improvement in fitness with those individuals that did 450 minutes of exercise. Now, I'm not suggesting that you tell your patients to do 450 minutes of exercise per week before going for a surgery. My point is that it does appear to be dose dependent. If you can get a greater dose of exercise into these individuals, even in a very short period of time, you can get some significant improvements in fitness. Now, whether those fitness improvements then translate into improvements in surgical complications and recovery, we don't know. We haven't looked at that yet. But again, I think I'd be happy to discuss maybe the future of where this could go. So that's prehab. What about during treatment? What are some of the studies that have been done there? So I'm just going to talk about two, I think, exemplar studies that have been done, actually both by my former supervisor, Kerry Kernier, who's in Edmonton, Alberta. This was the first study, which is now 15 or so years old, but I think it's an important study to talk about. This was a multi-site randomized controlled trial, 3-arm randomized controlled trial in 242 patients with early-stage breast cancer initiating chemotherapy. Patients could be doing any level of exercise before they come into the study. I think that's important to emphasize. There's lots of endpoints in the study. I'm just going to talk about the changes in fitness, and this was measured VO2 peak. So in the patients who didn't get any exercise, this is the control patients. As you tend to expect, there was a significant decline, about a 5% decline in fitness in about 17 weeks of chemotherapy. This is the group that did resistance training during that time. And what you can see right away is resistance training did not mitigate at all the significant decline in VO2 peak observed with control. So basically, resistance training was ineffective at preventing the decline in VO2 peak. Aerobic training, those individuals who got aerobic training, it did appear to completely mitigate the decline that you saw in the other two groups. In fact, there was a slight increase in fitness in the individuals who got aerobic training. This is aerobic training 3 days a week. But from this study, you would argue that really aerobic training is the way to go to prevent declines in fitness during adjuvant chemotherapy in early stage breast cancer. However, there was also a second trial that Dr. Koenier did and his colleagues a few years later. This time it was in 301 women with breast cancer initiating chemotherapy. This time what they did a standard dose of exercise training, which was equivalent to the aerobic training dose in the first study. High, basically they doubled the dose of aerobic training, or they also looked at the combination group. So this was the combination of aerobic and resistance training to see if that was more efficacious. These are the data. And you don't need me to tell you, I think it's pretty self-explanatory. In all the groups, there was a significant decline in fitness. They did not replicate the protection against the decline with aerobic training only. All groups, there was significant decline. Now, this was slightly mitigated by the group that did high doses, but again, this was not statistically significant. So from these studies, I think you could potentially argue that exercise might mitigate the decline, but there doesn't appear to be a difference between these different modalities. So what about after therapy? What is some of the data we know there? Again, there's been lots of studies that have looked at exercise training following the completion of cancer therapy. I'm not going to be able to talk about all the studies. I'm just going to focus on a couple of our studies, again, because I think they're informative. So this is a study that we recently finished. This was in 174 women who've completed breast cancer therapy, at least 1 to 5 years following the completion of their therapy. All these women had to be inactive, defined as performing less than 90 minutes of exercise per week to get into our study in the first place, and all had to be unfit, actually, to get into our study. So we measured their fitness levels before they came to the study. If they were too fit, they were ineligible. We only took individuals that had a fitness level below the age matched sedentary value. So these women were randomized to one of three conditions: either a control group that got stretching, or two different types of exercise training regimens, either something called a linear aerobic training program or a non-linear aerobic training program. So I'll just describe to you what I mean by these. So a linear training program is essentially the approach we take with most exercise interventions. There is a progressive, if you will, escalated period in the first 4 weeks of the trial where we increase both the intensity and the duration of the exercise sessions. Thereafter, every exercise session is roughly about 75% of a person's baseline exercise capacity, and each one of these sessions is about 45 minutes in duration. So this is the classic approach to exercise training. We call that linear approach. What we want to do is test something called the nonlinear approach. So this is the way that you basically would train if you're running for a marathon. Again, just in the interest of time, I'll just quickly describe it. Essentially now, each one of the exercise sessions is of a little bit different intensity. These exercise sessions range from anywhere from 55% of baseline exercise capacity. This would be a session in black, all the way up to kind of the red bars here, which represent an exercise session at about 95% of someone's baseline exercise capacity. All these other lines represent somewhere in between. So basically, you've got a mix of high intensity sessions together with lower intensity and moderate intensity sessions that gradually progress across the course of the intervention, and they're all mixed. Excuse me. So this is called a non-linear training program. So we basically wanted to test which one of these was more effective at improving fitness in individuals that had completed their therapy for early stage breast cancer. So here's the data. So this is the stretching group. This is the linear training group. This is a non-linear training group. This is fitness here on the y-axis. As you can see, in the stretching group, there's really no difference at all from baseline to post-intervention. You wouldn't expect them to. These individuals were not going through any form of therapy. The linear group, there was a nice improvement in fitness, as we know from prior trials. There was also improvement with non-linear training, but actually, this was no better than the linear training group. So both of these regimens were effective, but non-linear was really no better than the linear training group. I'd also mention, actually, which is important, the non-linear training group, actually the adherence rate was actually higher in this group. So individuals that are doing higher intensity sessions, you might expect that to be associated with lower adherence. It's actually associated with higher adherence, which was an interesting finding. Also of interest, actually, was the individual patient response in this study. So we're not only interested in what the mean response in terms of all the patients put together, but what was the individual patient response? And I think what came through on this, which was pretty surprising to us actually, is that the majority of individuals, whether they got linear training or non-linear training, didn't have a clinically meaningful response in their VO2 peak level. That 65% had an improvement of fitness that was below that, what we would be considered to be clinically important. And this is classically what you don't hear about exercise study. We think that exercise works for everyone and it works very well. Well, it turns out that maybe that's not the case. So based on that, we actually have now a new study that's underway that's looking to see if we can identify what the optimal dose and exposure of exercise training is in these individuals to minimize that non-response to exercise. This is the same eligibility criteria as our prior study. Now individuals are randomized either to standard exercise, which is 150 minutes for 16 weeks. They either get a greater dose of exercise, so they either get 300 minutes for 16 weeks, or they get higher exposure, so that's 150 minutes for double the length of time, so 32 weeks, or they both get intensity and exposure, so 300 minutes for 32 weeks. So this study is currently ongoing, and I hope the results are going to be pretty interesting. Just one study I want to mention, just to say that this is not all about breast cancer. We also just completed a study in about 90 individuals who completed treatment for early stage lung cancer. Again, all these individuals had to be inactive to go to our studies and unfit. We took individuals anywhere from 1 to 10 years following the completion of their therapy. It was a 4-arm randomized controlled trial, randomized either to stretching and control, aerobic training only, resistance training only, or the combination of aerobic and resistance training. Here are the data. This is the control group, aerobic, resistance, and the combination. This is VO2 peak. You can see in the control group, nothing happens. None of these patients were undergoing therapy at the time, so you wouldn't expect there to be any decline or increase in their fitness. The aerobic training group, we saw a nice improvement in fitness. Resistance training, we saw no improvement whatsoever. We actually hypothesized that we would see an improvement in fitness with resistance training because these individuals tend to be a little bit more frail, and we thought resistance training might improve fitness. It didn't. The combination of aerobic and resistance training was also effective, but I think you could argue that it was probably primarily due to the aerobic training component of this combination, because resistance training by itself really didn't have any impact. So again, the take-home message from this study, at least if you're looking to improve fitness in an individual who's been diagnosed with lung cancer and finished therapy, is maybe aerobic training is the way to go, but of course, other studies are of course needed. Now, just in my final study I'll talk about, I think an important question in literature and in clinical practice is if you have an individual who's been newly diagnosed with any form of cancer, the question might arise, when should I start exercise training? We know that we have data to support the role of exercise training during therapy. There's also evidence, of course, to support the role of exercise training after therapy. But I think often we hear that if individuals are going to go through therapy, if you're going to continue your exercise program or thinking about starting a new exercise program, maybe you should wait until your cancer treatment is finished to start a new exercise training program. You've got a lot going on. Maybe you start an exercise program at that time might be not the best idea. We felt that was an interesting question because we know the detrimental effects of what can happen in individuals who go through therapy but don't exercise train. You get that significant decline. So the question is, if you do have a new individual been diagnosed with cancer, when should you advise them to start exercising? So we designed a trial to answer that question. This, again, has not been peer-reviewed. This data literally is now just finished it. So please don't share this data. But I just wanted to share some initial findings. So this was a randomized controlled trial of what we consider to be the optimal sequencing of data for an individual who's been newly diagnosed with breast cancer. Sorry for the typo here. This should be breast cancer. So these women were randomized to one of four conditions: either aerobic training during their chemotherapy, they then transitioned to a control group after the completion of their chemotherapy. The second group either got their chemotherapy without any exercise training. As soon as they finished their chemotherapy, then transitioned to an aerobic training group. The third group got exercise training all the way through. And then the final group, which was usual care, got their chemotherapy as per standard of care. And then after the completion of their chemotherapy, they also just got usual care, no exercise training. And these are the data. So I'll just walk you through this. So the blue is the group that got exercise training during chemotherapy. The navy blue here, or the darker blue, if you will, is the group got exercise training after their chemotherapy. Green is the continuous group, exercise training both during and after chemotherapy. The orange is the usual care group. So this is from baseline to midpoint, which essentially is the time during chemotherapy. And you can see, consistent with the data from Kanye, all the groups have a decline in fitness, but the decline in fitness is mitigated in those groups that performed exercise training during their treatment. This is the concurrent group and also the continuous group. Now, in the second comparison here, we have the change from midpoint, so this is going from after the completion of chemotherapy to 16 weeks after the completion of chemotherapy. As you can see, all groups spontaneously recovered their fitness, but the groups that were performing exercise training during that period, sequential and the continuous group, their improvement in fitness was better than those that switched back to usual care, i.e. no exercise training. Just of interest, we're interested, what is the change in fitness across all the groups from baseline to post-intervention? So that's 16 weeks following the completion of chemotherapy. And the continuous exercise training group was the only group that had a significant improvement in fitness. All the other groups actually returned to their baseline or pre-chemotherapy level, but only the continuous exercise training group had a significant improvement in fitness. So again, I think the message here is, at least from my perspective, is for an individual who's starting their treatment, is you start exercise early and you continue exercise even after their treatment is finished. These are the individuals who are going to recover the fastest. So just to summarize the second part, I think we've shown that without exercise, you get this significant decline during therapy. This might spontaneously recover in certain individuals, but certainly exercise training, I think, can really accelerate or attenuate and accelerate that recovery. We're still interested in, if you will, a spaceflight approach where we do exercise training in the same cohort of patients before, during, and after therapy. We haven't been able to pull that off yet, but hopefully that's something we do in the future. Now, just in the last couple of minutes, I'm just going to talk briefly about where I think this might all go, or where I might hope it might go. I think if you look at the current status of exercise guidelines for cancer survivors, they're pretty generic. It's typically a one-size-fits-all approach. Same exercise recommendation, 150 minutes, and all patients will benefit equally from this dose of exercise. I think our data shows that that might not be the case. So what will a potential future vision look like? Well, I'm hoping that we can really leverage new technologies and innovation in digital technology to better personalize not only monitoring of patients, but also the delivery of exercise prescription to patients. So I think we can use digital devices, we can integrate this with EMR to really help predict and identify those individuals that are high risk for maybe physiological impairments. In those individuals, we can then prescribe personalized exercise prescriptions. So this is the conceptual vision that I have. So how does this look if we dial down a little bit? As you know, we've got lots of individuals now have wearable devices, whether that's in their phone or because they've got an iWatch or a smartwatch. From these devices, we can measure a lot of interesting outcomes and metrics, be it something as simplistic as steps per day, but also things like walking speed, these functional outcomes that I think can be very important. With an iWatch, you can also look at heart rate. You can also get estimated VO2 peak in these watches as well, which I think could be very informative. You can imagine if you had this type of information, we'd be able to monitor patients very, very closely in a way that's never been possible before. You can imagine if you're monitoring, say, somebody's mobility steps or VO2 peak, you know that treatment has been initiated in this individual, you could then monitor where a decline might happen, and you would then be able to do something about that, and be able to monitor in a fashion that we currently are not able to do. You imagine that each patient's trajectory might be a little bit different when they initiate treatment. Right now, we don't see these patients as often as we might like. So this will give us, I think, real-time feedback of how these individuals might be doing during their treatment. We can then monitor these patients in such a fashion that will give insights then we can predict maybe when a patient might be experiencing toxicity from treatment, so we can intervene earlier to offset that toxicity happening. If we're able to monitor these patients, I think with high resolution data in a way that's not been previously possible, then I think this will inform the way that we can intervene. You can imagine a scenario where we've got 3 different types of patients, all of which are going through a trajectory as they go through cancer therapy. Each one of these patients, you can see their experience is very different. So therefore, the types of intervention or the types of exercise intervention this individual needs, you expect might be very different. With individual number 1, this is the individual that seems to be very well and then crashes quite quickly. This individual might need a more intensive exercise intervention and monitoring, might require a little bit, actual one-on-one support to get exercising because they're not doing so well. Individual number 2 seems to be flatlining. They seem to be very well, not experiencing toxicity. With this kind of individual, probably don't need as intensive monitoring, maybe just monitoring by their phone, maybe the occasional check-in to make sure they're doing okay. Individual number 3, again, appears to crash a little bit, stabilize a little bit. Maybe this individual doesn't need as intense exercise training and prescription. And maybe they're also going through something like hormone therapy where glucose monitoring might be actually more indicated. So you can personalize the types of surveillance that you might need depending on the type of treatment the individual is going through and the type of anticipated toxicity this individual might get. Then, of course, you can then monitor these individuals in a longitudinal fashion. Again, this will give you information. Are they responding to the exercise training program that I give? Do I need to modify it? Do I need to discontinue it? And so forth. So obviously, this is obviously very much a blue sky vision, but I wanted to put it there because I think it might be an interesting point of discussion. So just to conclude, I think the current progress in exercise oncology, exercise rehab in cancer, I think we've made incredible progress over the past 15 years. This is a field that really didn't exist over 20 years ago. And I really do think we have a reasonable evidence base right now. The guidelines we currently have are generic, but there always probably will be generic because I think guidelines are like that. I think it's going to be really up to the clinicians to personalize the information that we have from these studies to really do the best job that we can for the individual you have that's in front of you when they come to clinic. Obviously, we're going to gather more information as we do more studies, but I think really personalization is going to be the key. And maybe there's a future for integration of digital solutions and technology into rehab. I really think this is the way that it needs to go. But of course, a lot needs to happen before we can do that. But again, I think that would be very interesting to discuss. So with that, I'd just like to thank you so much again for the honor and privilege of presenting today. It's been a huge honor. I'd just like to thank my team, all my collaborators, and the funding agencies that support our work. Thank you very much. I'm happy to take any questions.
Yeah.
I have a question. Hi, Dr. Jones. I'm Kathy Marshall, a prostate cancer medical oncologist here at Hopkins.
Kathy, how are you?
Good. Thank you so much for that talk, and thank you to Tom's family for supporting this work. I've had the opportunity to talk to him many times to try and develop an exercise protocol in prostate cancer with Dr. Jessica Engel from PM&R. So that's the work that we're, part of what he's helping to support, which we're doing in prostate cancer. So I wanted to ask you and get some insight from you, one on recruitment challenges and how it's been accepted by patients, and if you've noticed differences, especially with regards to tumor type or where people are on the cancer journey. For example, if they've completed all of their therapy and are considered cure versus people who maybe are like right around the time of diagnosis or changes in treatment. And then also if you've looked at any of the tumor markers, like for example in the prostate cancer exercise trial that you mentioned.
Yeah. So yeah, great questions. I'll answer your first question first, and then we can go on from there. So yeah, recruitment to these types of studies is always a massive challenge. Recruitment to any clinical trial is a massive challenge, of course. I think to these trials, I'm not being biased, but I think it's even harder. You're asking individuals to come in 4 or 5 days a week for an extended period of time. And that was basically the impetus for why we designed this digital approach. When I moved from Duke to MSK, I'm like, oh, I live in a city of 1.8 million people. I'm going to have no problem recruiting to our studies. That didn't turn out to be the case. People wouldn't even come from the west side to the Upper East Side to come to our studies. And, the reality is that 70% of our individuals at MSK come from outside of Manhattan, right? So it was fine if we wanted to recruit a few people who lived on the Upper East Side, but that wasn't going to do it. So the trick was that we needed an approach that we can maintain delivery of exercise at high fidelity, but also leverage the convenience of being at home. So one of the approaches to that, of course, is giving individual Fitbits and things like that. But we really felt that we need to be able to quantify exactly what individuals are doing. So we designed that approach. So to answer your question, when we had our first model of individuals coming into our center, that was a real challenge. Less than probably 5% of eligible patients were able to convert to get into our studies. And this is studies that were on the shorter side, because we knew they had to be on the shorter side, because there's no way we're going to get somebody to commit to 6 months of exercise training coming to a center. So now we've got this new approach. We can recruit from anywhere in the tri-state area, anywhere. So our recruitment rate's gone from about 5% to about 30%. So it's not 100%, it never will be, but 30% of eligible patient is actually pretty stellar, actually. And I think your sub-question within that, have we seen any differences by cancer type or stage of where they are across their cancer journey? We haven't. This preoperative window of opportunity, we thought we were struggled with that because, it's an intense period, people are stressed because they're going for surgery. The accrual's been amazing. But we've also got a trial in women with metastatic breast cancer. The accrual to that has been amazing. So we haven't seen those differences. And I think it really lends to the fact, I think people are surprised, like, you're going to send me a treadmill? What? And I'm not saying it takes away all excuses, but it really helps. So I'll just finish with that before I go into your second one. Do you have any responses to that? All good? Okay.
Yeah.
So in terms of tumor markers, I actually had 2 talks prepared. One was on physiological toxicity. The other one was on tumor biology. I chose this one. But yes, that's the work that we're doing now. Is we're interested in tumor, not only changes in response to exercise in terms of tumor biology, but also do tumor molecular features predict how the tumor responds to exercise. So in terms of the first part, we've done RNA-seq in all those prostate cancer samples, and we're seeing pretty remarkable changes at a gene expression level, which is consistent with the work we've seen in mice, where you actually see, one of the findings is increased infiltration of immune natural killer cells into the TME, into the tumor microenvironment, which I think is pretty cool. We're also replicating that in our human samples as well. We've got data in mice showing that also tumor mutational status appears to predict response to exercise. We haven't done that in people yet, but that's something we're very, very interested in.
Great. Thank you so much.
Of course.
Very good. I'd like to ask a question, if possible. Thank you so much for this. I'm sure Tom is smiling down on us. It makes me miss my dinner conversations with him. I was lectured a lot over dinner. And I'm a social scientist, so I was always asking about the role of depression in these studies. have you been looking at any intervening variables around mental health and depression in particular, and how it impacts the willingness to participate and then adhere to the program?
Yeah, great question. And thank you so much for being on the call, Patricia. I really appreciate it. We haven't, there's other studies that have looked at depression using I think the CESD as a measure. And show that exercise decreases patient-reported level of depression using that scale. Although I think the caveat, this is not recruiting individuals that might be depressed to begin with. So that's the caveat, if you will. We haven't looked at that in our particular studies. We have looked at things like anxiety, general quality of life, fatigue. They're measures that typically, again, on the whole, tend to get better in these studies, but not all those measures. And again, the caveat with those, we haven't recruited necessarily a patient population that might have high levels of fatigue to begin with, higher levels of anxiety to begin with. And in fact, I think across most of the studies, at least in exercise and cancer, that's also been the case. We report all the time that exercise improves fatigue, but it's in individuals who don't really have fatigue to begin with, which I think is important. So, do those things correlate with adherence? I think maybe not. My background, actually my Ph.D. was a little bit in social psych as well. So, if you look at the behavioral constituents of the way that we go about our intervention, there's a lot of behavioral constructs that are built into that on purpose. Yes, we send them a treadmill, but every call is one-on-one. We get rapport with the individual. We get to schedule when it's convenient for them. All these things that I think ultimately build self-efficacy. So, the adherence levels in our studies are pretty remarkable, 85%, even over a year of training. This is training 5 days a week for a year straight. I'm not making this up. I mentioned that we had that one dosing group where men trained 475 minutes of exercise a week. The adherence rate was 93%, 9 individuals. If you told me that, I wouldn't have believed it. And yes, that's for a short pace of time, but I think it's because of, we do build, I think, a lot of behavioral constructs into our study interventions. I think that really helps with adherence. So, fantastic question. I think we do measure patient-reported endpoints, and we will be able to look to see how the change in some of these patient-reported endpoints correlate with adherence and other measures. So we'll certainly be looking to do that. And fantastic question.
Thank you so much.
Robert Thurston there has raised a hand. You going to ask the question?
Yes. Yes, and I'm related to Tom through marriage. Anyway, consider him a brother or cousin or something. But I'm a runner, and so it sounds like the things you've explained, Dr. Jones, kind of say that that's a good thing to do, to keep running. And I run about average 3 to 5 miles, not every day, but most days. So I guess I have 2 questions. One is, does it improve? Oh, I didn't say this. I'm diagnosed with stage 4 prostate cancer, so it's metastasized, and just treating with hormonal therapy. I should need to say that. So is it better to step up and run like 10 miles instead of 5 miles? And the other question is, it sounds like you're saying resistance exercises are not nearly as important as fitness exercises. And so I'm a little bit questioning that, because I feel like I'm losing weight, I think, because muscle mass is kind of seeping away, and it seems like exercise would be helpful. So I want to throw those to you. Thank you.
Yeah, thanks so much for the excellent question. If I forget any part of your question, just remind me, and I'll try and answer it. So great on the running. Yes, you actually wouldn't be eligible for any of our studies because you're already too active. You're running already too much, which is great. So yeah, so in terms of if you're running, I'll answer that first. Yeah, the only thing, I mean, it's hard for me to give specific advice in the context of this call, but what I would say is, if with your running, I would say if you try and stay away from running the same distance and intensity every time that you run, and so not necessarily going for a 10-miler instead of a 5-miler, but on some of those runs, think about intensity. Some days are going to be a lot easier. They're good, but might be a bit longer. So you might do 6 miles, but a little bit easier. Other days you might only go 2 miles, but go a little bit harder, if you will. So now you're varying both the duration and the intensity of those stimulus, and that will give you more of a physiological bump, if you will. And if you've trained for a marathon, that's how you would train. You wouldn't train just doing long, slow distance. You would vary it up. So that would be my advice on the first. On this, in terms of the second part, resistance training, I actually think resistance training is incredibly important. And please don't come away from this thinking that resistance training isn't. I really did. It was in that one particular study where we didn't find that it was particularly helpful. But that doesn't mean in general that it isn't. Particularly as you start to get older, you lose some muscle mass. So resistance training in that context can be very advantageous for maintaining your muscle mass, maintaining your posture and balance and other things. And it's particularly important, of course, for running. So I would encourage you to maintain your resistance training and also to keep running, because I think you look great, and I think whatever you're doing is working.
Thank you.
Thank you.
So, Dr. Jones, this is here Pablo Salnik. So some of you who are outside the department don't know, maybe I'm the director of the Department of Rehab here at Hopkins. So I just have a couple of comments and that I'd like to share. One is thank you to Tom and the family and friends of Tom for really provoking these conversations, for the support to the PM&R department, and very especially for joining us here today and asking questions to the group. It's been really a pleasure to have you here, and love the curiosity and asking the questions. Dr. Jones, I really appreciate your talk. I think it's really, really enlightening. I just was going to point out, that your way of thinking is very similar to a lot of things that we have been doing here in the department, and this idea of doing personalized interventions. We have a center of excellence in precision rehabilitation that is exactly this concept of measuring function of the person in the community, in the regular life, taking advantage of all these tools that we have now available for measuring activities on people. And very much to the point that Patricia was asking, we are not only looking at the physical activity, but we're also looking at the cognitive and psychosocial aspects of function. Yep. And unfortunately, we haven't arrived to the space of cancer. We've been doing this in the space of COPD and stroke. But within that, similar concepts really are emerging. So I really enjoy your conversation on this. And maybe in a specific comment about the talk is, it's remarkable that you show, and your data points to that these individual differences. Even in your dose escalation study, you see that those who are doing the 450 minutes, some people have the same benefit of doing the 90 minutes and so on. Yep. And yes. So I think that, and since I'm pretty lazy to do exercises, if I can do the 90 minutes, I will definitely choose that one instead of 450. But so any thoughts on how you predict, or any thoughts on how you go about understanding who would benefit from the higher versus the lower, or so on?
Brilliant question. To use my English, brilliant question. So it's interesting. Yeah, we talk about the maximal, but yeah, it's like, what's the minimum I need to do to get the maximal benefit, right? So the honest answer is we don't know, because we don't have the data yet. But this is something that we're very, very curious about. We're curious about this from both an improvement in physiological outcomes, and also actually tumor-related outcomes. It comes back to the question I think Kathy answered earlier. So we do see this heterogeneity in response in one of the studies I presented, which is the 174 individuals with early-stage breast cancer. We are now going deep into that study to try and identify what are the characteristics of those individuals that had a really incredible response to this uniform delivered exercise versus those who didn't? Because maybe in those individuals, the ones that have a really nice response, maybe they don't need 160 minutes. Maybe they just need 90 minutes. Maybe there's some individuals in there who do need, the greater dose. From a clinical perspective, that data is incredibly, I think it's one of the most important questions we have, because right now it's everybody gets 150 minutes. And I've always thought that doesn't make any sense. Doesn't make any sense. What's interesting is you brought up that the study, you do see in general, if you look at all the patients, that dose response. Now, if I put in the tumor response, you don't see that. Normally if you look at cardiovascular disease, for example, you normally see this very nice linear response. The more exercise appears to be, the better benefit. But if you then replace that with something like risk of recurrence, you don't see that same relationship. You kind of see a plateau. Once you get to a threshold of an exercise dose, increases the amount of exercise doesn't give you any additional amount of benefit. I think that's fascinating and something that we are looking at very carefully. That's all I can tell you. We don't have any data yet, but maybe I can come back when we have that data and we can talk about that.
Absolutely. I'd love to hear more about this and finding that, what is the critical interaction? I mean, what's driving the critical interaction between exercise and biology of cancer?
Exactly. Yeah.
All right. Thank you so much. There may be one or two more questions, if it's okay with you, Dr.
Absolutely fine with me.
All right. All right. We have two Roberts here. You're raising your hand, so go ahead.
Hi, I'm Delaby, and I'm one of Tom's in-laws in-law. I went through that eye surgery where you have to have your head down and all that kind of stuff. And I didn't start taking notes on how I was progressing until like 2 or 3 weeks after the process. Do your participants keep a regular log of how they're feeling so that you could have some idea of whether they're keeping up their practice is based on how they're feeling, or they just lost it? It just feels like if they were giving you a record of their progress and how they felt, that you'd learn a lot.
Yeah, great question. There's no doubt that I would like to ask people every day how they felt. The problem with that is you get a little bit of burnout with that if you're asking individuals same questions every day, and your responses start to become automated. I'm not an expert in psychometrics, but I believe that's the case. So in our studies, we will ask what we call patient-reported endpoints, questionnaires. We'll deliver those at the beginning of the study, halfway through, and typically to the end, not on greater frequency as we would probably like, because we're a little bit cautious about overburdening our participants to complete too many questionnaires. But this is where this physiologic data comes in. I think it's very nice because it's completely passive. What I mean by that, they put on the watch, and we get that data whether individuals are thinking about it or not. Now, that doesn't tell us how they feel, but it does tell us about how they are functioning every day, how they're going about their normal daily lives. So yes, it's not exactly to the information that you need. Of course, if you have both side by side, that would be incredibly powerful. But I think there's a threshold about how much we can ask individuals to do and write down all the time. So to answer your question, we try to do it, but not as much as we would like, but we are also trying to be a little bit practical, if that makes sense. Great question.
And maybe the last question, maybe Robert Schleip, is that how you say it? Schleip?
Yeah, thank you. I'm a colleague of Tom in Germany. And first of all, a brilliant presentation. Tom would be delighted. I know him good enough. This is perfect.
He'd be grilling me right now, Robert. He'd be grilling me.
Yeah, I know, but that's the way how he showed respect. In the last 2 presentations that he gave in Germany, he presented his considerations that the law method of resistance training, which is an unusual way where you build up the resistance from set to set, would be more efficient than conventional resistance training.
Right.
And he had some early indications, but when I asked him how sure he is, he told me he's not sure. So my question is, do you have any indications on research on that, or plans for research, or any data about it?
We don't. Most of our studies have been aerobic training based. The results we got without resistance training in lung, quite honestly, were surprising and disappointing. To be honest, we really expected that resistance training would be effective in that particular cohort, and it really wasn't. The data's the data. This is why you do the studies. This is why you need the studies. Now, of course, it could have been the fact that the resistance training program that we prescribed wasn't good enough. It wasn't, sure. It was a pretty standard, but it maybe needs to be more personalized. Maybe it needs to be designed differently, like Tom was talking about it. So I think that question remains to be open. The problem we've had resistance training is because now we've got this remote approach, it's been challenging to remote deliver resistance training programs in our individuals at high fidelity. You can send individuals a bunch of dumbbells, but then to do it properly without injuring, I think is going to be difficult. We haven't cracked that problem yet. So maybe somebody else has, and they can tell me. But I think there's more questions than answers, as there is in most fields.
Great. Well, again, thank you, Dr. Jones, for joining us today and really having this conversation. It's been terrific. And also, one more time, thank you for Tom and family and friends for joining us here today. I couldn't agree more with Lauren's comments about having this conversation between the researchers, the clinicians, and the patients. The customers. We are all customers at the end of the day, though, but it's very enlightening. So thank you, everyone, for joining us today, and I hope you enjoy the rest of the day, and let's continue being in touch.
Thank you so much, everyone. It's been a pleasure.
Thank you.
Have a good afternoon, evening.